I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski. I'm the host for the Vasculitis Foundation Educational Webinar Series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsor, Novartis, for supporting these webinars. Today's webinar is Airway Disease in ANCA-Associated Vasculitis with our guest speaker, Dr. Alexander Gelbard. After we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who's registered will receive an email with a link to it as soon as it becomes available. But before we get started today, let me just go over a few details. This is a live webinar, so we've muted everyone except our guest speaker. In today's webinar, Dr. Gelbard will do a presentation. After his presentation, you'll have the opportunity to ask him questions. And let's see if I can share my screen to show you all how to do something. There we go. These questions will be asked by typing your questions into the Q&A box. If you don't see it, click the three dots to the far right of your screen where it says More. Please make sure your question is a general question about today's topic as it relates to vasculitis, as Dr. Gelbard cannot comment on your specific medical situation or medication. If you need closed captioning, you should look for the box in the bottom left corner that says Captions. I think it actually says CC, like in the picture. It might be also under the word More. And there's a chat box for you. The chat is for you to chat with other people in the webinar or the Vasculitis Foundation staff. But please remember to use the Q&A box at the end of the presentation for your questions. Hopefully this slide has helped you all be able to figure out all I have to do is stop sharing now. Let's see. There we go. Hopefully this slide has helped you figure out how to find your boxes and know where to ask the questions. So now that all the housekeeping is done, let's begin by introducing our guest for today. Dr. Alexander Gelbard is the Vice Chair of Research in the Department of Otolaryngology, Head and Neck Surgery at Vanderbilt University in Nashville, Tennessee. Welcome, Dr. Gelbard. It's so great to have you here with us today.
Thanks, Kathy. Appreciate the invitation and the chance to meet and talk with everyone.
Great. And before you get started, if you have any disclosures, would you tell us about them?
Sure. No disclosures to make, but I'm open to any invitations, in the audience.
Okay. All right, everyone. Dr. Gelbard's going to get started. And if you want to test out the Q&A box before we get started, I'm happy for anybody just to put your question in there just so everybody can find it. And it's all yours, Dr. Gelbard. Thank you.
All right. Well, appreciate everybody taking some time to talk and listen today, and looking forward to hearing some questions from everyone after we go through my basic pearls and pitfalls of airway disease and granulomatosis with polyangiitis and vasculitis in general. So specifically for GPA, I think a lot of people know that there's several parts of the body and several organ systems that are affected. These include the lung and the trachea and the larynx, otherwise known as the voice box, but also the kidneys, as well as the eyes and the sinuses and the skin, as well as the central nervous system. Most of what I'm talking about today is the larynx, trachea, and lungs. Although everything's obviously interrelated, that's sort of my area of expertise, and that's the set of problems that's particularly tricky sometimes that people come in to see me about. So what is this area? What is this airway? How is the airway different than lungs? And if a picture is worth 1,000 words, a video's got to be worth about 1,000,000. And so that's easy for me to pack in an explanation by just showing you this video. So standard airway, you can imagine that your lungs are taking in oxygen that moves past your voice box and windpipe. So when we think of the airway, you have your lungs, which constitute your lower respiratory tract, and then the large pipes that connect the outside world to your lungs, we think of as your upper respiratory tract. Specifically, your voice box is this area at the very top of the screen, comprised of two moving vocal cords that open to breathe and close to talk. And as you move just beyond this area, you have your subglottis, or below the glottis, and then your trachea. And so those are the main areas that we're really talking about today. Your vocal folds, otherwise known as your larynx or your voice box, your subglottis, which is the area just below your vocal folds. Another word for larynx or vocal folds is glottis. So subglottis means just below the vocal cords. It's kind of where the top of the trachea and the bottom of the voice box meet. And then you have your trachea, and then where the trachea splits off to go into each lung, you have your bronchi. Your main stem bronchi are at the top, and then they branch off into smaller subsegmental bronchi. And these are all areas where people with GPA or vasculitis can run into trouble. And so, what does that look like? For laryngeal stenosis, the vocal cords can get stuck pretty close together and blocked by scar. For subglottic stenosis, that inflammatory remodeling can really narrow the airway just below the vocal cords. And in bronchial stenosis, you can see one of the main stem bronchi is really pinched off at the red arrow where that gets very narrow. And each one of these is going to have different symptoms and manifestations. They'll all create problems where you feel like you can't breathe that well. And so they're all things that we need to be aware of and help address in this disease. Well, what's the most common? If we look at a bunch of people who have GPA and also have airway symptoms, subglottic disease is the most common by far. But there are, a number of people, probably about 15 to 20% that'll get bronchial stenosis and about 5 to 10% that'll get laryngeal stenosis. And you can have several of these together, but by and large, the biggest problem usually is subglottic stenosis. And of all the people who have GPA, who has airway disease? Well, if you looked at about 1,000 patients and asked who has airway disease, subglottic, bronchial, laryngeal, it's about 15%. So it's sort of a smaller subset of patients with GPA that have this level of problem. I think one question everybody usually asks as they start to take care of this disease is, why does this even happen? And there is still a pretty big mystery. People have spent a lot of time trying to figure this out, and they have a lot more insight than they did 10 or 15 years ago, but it's not completely understood. Um, the large genetic studies that the Vasculitis Clinical Research Consortium has performed has really made it clear that there's about 14 genes that really put you at risk for developing GPA in general. There certainly can be other influences as well, but those seem to be the strongest influences that put you at risk for developing GPA. You might say, well, what do those genes do? If you look at this picture, which is a map of the cells in the airway, and you look at the red color being cells that have these genetic variants, what you notice is that most of the red shows up in immune cells. So, as many people probably understand, GPA is an inflammatory autoimmune condition where the genetic variants seem to put your immune system on hyper alert to be overly aggressive. And that's why a lot of the treatments are aimed at quieting down the immune system. But the same things sort of manifest in the airway. Like I was saying, it's not just probably genetic variants alone. There's probably some environmental influences as well. In sort of this smaller look at 10 patients early on that we had with GPA and airway disease, you could see a lot of them had Staph aureus that you could culture from the scar in their subglottis, whereas other patients who have other scars in their airway from other reasons don't usually grow out Staph aureus. So it seems like this may be an environmental trigger or maybe just a marker for people who have the disease. But those are some of the aspects of the airway disease and the risk factors that I think we understand pretty solidly right now. But the real question I'm sure most people who are on here, are asking is, well, how do you take care of this and what do you do to manage it? And it's complicated because it can be very life-threatening. And so you really need a multidisciplinary team. That would be one of my main points. And I'll go over some of those points at the end also to reiterate. But I think the biggest thing is having a good team of rheumatologists, otolaryngologists, pulmonologists, and even thoracic surgeons who all can work together to help provide different levels of expertise specific to your problem. One of the mainstays of treating GPA and the airway obstruction is endoscopic treatments, meaning going through your mouth and trachea to be able to open up that area of obstruction. And what does that look like? Well, for subglottic disease, we have patients who are, well, I'd say before getting started with endoscopic treatment, one point I should make is that one way we can take care of this is tracheostomy. So tracheostomy bypasses that area of blockage. So in terms of treatment strategies for obstruction or blockage in the large airway, you can bypass it with a tracheostomy. Obviously, that comes with a lot of quality of life changes and impact. And so it's not the first line treatment for everybody, but for certain patients, it's very vital to keep them alive and breathing well. And so that's a mainstay. That's a really established treatment strategy. For some patients who don't have as severe disease, the other management strategies include endoscopic management by going through the mouth and even open reconstruction to help remove the affected airway and sew healthy trachea to healthy voice box. So, what does a tracheostomy look like and where does it go? You can imagine that it's a tube that's going into the airway below the level of the blockage in the voice box. In terms of endoscopic treatment strategies, if you're looking at the scar through the mouth, we can cut the scar, sometimes with a little laser, sometimes with little scissors or a small knife, and we put in anti-inflammatory medicine, usually the same kind of high dose steroids that people receive orally, some version of that we can put in the soft tissue. And then we use a little balloon to expand that area of scar to improve the caliber of the airway. So that's endoscopic dilation, and that is very effective. And when done at a center, I think that does this a lot, can be very safe and really restores people's breathing quickly and does not have much recovery time. So we feel like this is a real mainstay of treatment. We also have more advanced options when people have recurrent disease or they're left with a lot of scarring as the disease quiets down, but the scar isn't easily reversed with some of the medicines that we use. So open reconstruction are much bigger surgeries designed to take out the scarred portion of the airway and sew healthy voice box to healthy trachea. These are not often offered in GPA just because there's such a big inflammatory component that people aren't always in the ideal state to heal, but they are utilized. And so it's important, I think, for everybody to hear about them at least. I'd also say that with current strategies and medical treatment that has improved so much over time, it's not super frequent that these bigger surgeries are necessary. But what do these surgeries involve? Well, they involve taking away the area of scar in, say, the subglottis. And so the way we approach that is by removing the structures on the very front of the neck, cutting out that affected area of trachea, smoothing out the very bottom of the voice box and removing any extra scar that's there, and then sewing healthy voice box and healthy trachea together with stitches to bring them back together. And you can see the little yellow lines on the side of the screen are the nerves that control your voice box. So we have to be very delicate in this surgery to keep those nerves from being too irritated afterwards in order to maintain good vocal function and good breathing function. So those are some of the major treatment approaches that we have at our disposal as surgeons to treat airway obstruction when people come in and don't feel like they're breathing that well. There certainly are medicines that we can use to temporize things. One of the mainstays being corticosteroids that I'm sure a number of people have gotten before. Those aren't a good long-term strategy for airway disease. Usually we're able to make things a fair amount better with surgery, but we really interact closely with the rheumatologist to help guide medicines and medical treatments in order to bridge people between the time when they see us and when they need surgery. So this is a pretty representative case, I think, that illustrates some of the complexity that can happen in the airway for people with GPA. So a 32-year-old woman showed up to visit with us, feeling like she couldn't breathe that well. And she had had a CT scan at an outside hospital, which showed some level of subglottic scar. She carried a diagnosis of GPA, and so we were, very interested in helping understand, what the major cause of her symptoms were. Some degree of subglottic scar is evident here, which you can see in the picture, where it's that thickening kind of within the ring, that gray thickening that's kind of reducing the size of the black. But at the same time, this seemed a little bit of a mild case of subglottic stenosis to me, and I couldn't really understand why she felt so bad and why her dyspnea symptoms were so severe. So we also got a chest CT. And in this chest CT, you can see the other thing that can happen in disease is the left and right mainstem bronchus had a thin film of stenosis. So that when you look close, you could see this thin film moving across the mainstem bronchi, kind of blocking things. There's the right and there's the left. And if you looked closely endoscopically in the operating room, you could see that there's almost no room for oxygen to get down into her lungs at all, with this little sliver on the right and a tiny hole on the left. And so it was only because she was very young and very healthy that she was really surviving at all with this. And so I think what this shows you is that it's important to get pretty aggressively evaluated if you have GPA and you're having trouble breathing, to understand where the airway problem is. Is it at the level of the voice box? Is it in the trachea? Is it in the subglottis? Is it in the mainstem bronchi? Because when disease in the mainstem bronchi, I really needed the interventional pulmonologists to be a part of helping take care of this patient. So looking at the subglottis when she was asleep, you could see this kind of subglottic scar, and you might say, well, hey, what's normal and what's scar? And in the picture in the middle, all the area that's green with this fluorescent dye that really lights up with inflammation, you can see where that scar is inflamed in the middle of that airway. And so cutting that scar with a little knife, injecting steroids, using a balloon, it opens up very well and gets back to near normal size, on the right. Same thing with the mainstem bronchi, but with a different location and a different set of tools. And so the interventional pulmonologists that I work real closely with were really vital at helping improve this and taking that small dot on the top of the screen and enlarging it to make it so that air could move down to the lungs. So this is really a life-saving procedure that the interventional pulmonologists helped with. Um, you might say, well, what can we do to keep the disease from coming back? Because that's one of the problems that can happen is even after we open things up, that inflammatory disease or that scar can come back and produce symptoms again. And so that's important. So it's very important if you do have airway problems to have an otolaryngologist and a pulmonologist and your rheumatologist checking pretty regularly to see how you're doing to make it easy to intervene if we need to. Usually it's not terribly frequent, but the disease in the airway can come back. And so one thing people wonder about is, well, how do I keep it from coming back? And if we use stents in the heart to keep the coronary arteries open, can't we do those in the airway also? And while I think that's a good idea, and in principle it seems like it makes sense, the airway is actually pretty active, where you have an inflammatory response to foreign bodies, and you're also making a lot of mucus in a thin film that coats the whole inside of the lungs and traps viruses and dirt and debris. And that's getting pushed out all the time. We cough it out or swallow it and we don't even notice. So when you have a stent in there, that really disrupts that mucociliary flow and can promote a lot of inflammation and accelerated scarring. So stents aren't used as a mainstay of treatment for this disease. They can be temporizing and there's a place for them. And sometimes in the lower airway to keep things open for a while, if it's really severe, we use them. But it is not a cure-all that we use to fix everything. And one of the reasons why is that they can migrate. And so you can see here somebody with subglottic scar looking at their airway from the side. As you put in a stent, which is that kind of plastic pipe you can see kind of in the midline, it helps open up the airway. But over time, it's not really secured with any stitches, And so it can fall down and move farther down the airway. And you can see here where it's moved farther below this area of stenosis. And that can be really life-threatening because you can't take it out except in the operating room. So airway stents can be used in selected cases, but they're not usually a mainstay of how we take care of this. Most of the time, it's endoscopic management, augmenting this with other modalities as we need to. So just to kind of summarize this a little bit, GPA can cause subglottic stenosis in a significant portion of patients, and this frequently requires endoscopic management to improve patient symptoms. Tracheobronchial stenosis can also be caused by GPA, and this can require a combination of systemic and local treatments from additional providers like interventional pulmonologists or thoracic surgeons, in addition to otolaryngologists. Tracheostomy, in some cases, especially with severe laryngeal or subglottic disease, tracheostomy can be necessary to ensure adequate breathing. Um, and as I mentioned, open reconstruction is a possibility and can be considered in certain cases, but it isn't a mainstay of how we take care of this for most people. I think, like I said when we started out, one of the most important things in this disease, since it's so complex and it can involve multiple locations, and it has components that require surgeons as well as medical doctors and rheumatologists, is having a good multidisciplinary team. And so effective management of GPA really requires a collaborative effort that needs rheumatologists, otolaryngologists, pulmonologists, thoracic surgeons, and other specialists, depending on how the disease is affecting you. Um, Early diagnosis intervention, I think, are crucial, like many inflammatory diseases, to prevent irreversible organ damage. And so trying to catch things early and staying on top is something we really harp on. And as part of that, regular monitoring of airway disease activity is essential to adjust treatment as needed. And effective care coordination is really crucial to making sure the treatment people receive is pretty seamless and all the doctors are talking to each other about their perspectives to provide the best possible care for patients. So I know that's a lot of stuff, but I really appreciate the chance to talk. And with that, I would just say I'd open it up to any questions that people have in the chat to try to give you some information about your disease and how we treat airway manifestations.
Okay, that was great, Dr. Gilbert. Thank you so much. And we have had a few questions come through, so I'm just gonna see if I can find them. There they are on my screen. Some really good questions. The first question, now I know you've spoken mainly about GPA, but a question did come up saying with EGPA, ANCA-Associated vasculitis, what is the significance of decreased DLCO? How is it determined which pathway could be causing the decreased DLCO if it's not pulmonary hypertension? Is this something you can answer or move to someone?
Yeah, I think, I would give some perspective on it. The DLCO, or diffusion capacity, refers to how oxygen, once it's in the lung, moves into the body, moves into the bloodstream. So in order to get oxygen in your body, you have to take a big breath. The air goes through your mouth and nose, has to go past your voice box, through your trachea, and then down those main stem bronchi, ultimately ending in these little dead end sacs called alveoli. And those are your lungs. Like a sponge, these little sacs have a very thin membrane that oxygen hops across from inside the lung into the bloodstream. The bloodstream covers the outside of these alveoli. So if you get inflammation or scarring, like you imagine if you sprain your ankle is swollen. If you get inflammation or scarring in your lungs, those thin membranes in your alveoli get thick and swollen, and it makes it hard for oxygen to jump across. So most of the time, a decreased DLCO indicates problems in the parenchyma or tissue of the lung that makes it hard for oxygen to hop across.
Okay, well, thank you for answering that for us. The next question, someone did ask in the chat, and I'm going to ask folks to try and remember to put in the Q&A box so I won't miss you, but it's a good question. It says, can you review the symptoms of airway disease?
Yeah, I mean, the biggest one is shortness of breath. So feeling like you're just out of breath, and you can't explain it. And this is usually worse with exertion. So when you're trying to walk up a flight of stairs or walk across a parking lot or walk through the supermarket aisle, you notice yourself feeling very short of breath that you can't explain. Sometimes, depending on where the narrowing in the airway is, this can make very harsh sounds when you're breathing in. You can almost, tell across the room when somebody has airway obstruction if it's very narrow and they're trying to breathe in because it creates this very harsh kind of sound when people are breathing in. And if you have inflammation of your vocal cords, it can change how your voice sounds, where it can be rough and not the same kind of smooth pitch that we have during the day. So, mainstays of the symptoms would be breathing difficulty. Sometimes it can be noisy breathing, sometimes it can be voice changes. Those would be some of the main things to look for.
Okay, and to just add on to that, because I think the clarification will help, there is someone asking about, can it also cause swallowing difficulties with food and liquids? This person she says she seems to be choking on food and liquids, and she doesn't know, is that related to her vasculitis?
It can be sometimes, especially, swallowing and eating. We really take for granted how automatic it is. And so if our breathing is disruptive and the timing of our movements is thrown off, that can make it hard to swallow sometimes. If the vocal cords don't work well and they don't close when they should, sometimes food and drinks can spill down in the airway and cause you to cough. Um, it's not always associated with the airway disease swallowing trouble, but it is worth checking out because it can be. It can also come from inflammation or scarring in the esophagus, which is what a different pipe that carries food and drinks as you swallow.
Okay, interesting. The next question is, do you see patients who have GPA under control according to their blood work, but may have airway restriction in a bronchial tube?
Yeah, I mean, we do see that. So we'll see patients that have GPA where their markers are quiet and other symptoms they had initially of their disease are quiet, but their airway disease is still active, meaning we can make them better with endoscopic treatments, but then over time, their symptoms will come back and they'll feel like they can't breathe again. So we have to kind of help repeatedly over time. And so, yes, we do see that. And um, we like to think the medical community thinks that if we can control the medical components of disease and really keep the disease quiet in general, the airway settles down. And that's probably not completely true for everybody. The airway disease can run probably independent for some people of the rest of their symptoms.
Okay, and I did want to say to some of you that are asking questions that are very specific to your medical situation, Dr. Gelbart can't answer those because you're not his patient and he doesn't have intimate knowledge of your personal situation. So you can certainly reach out to the Vasculitis Foundation and see if you can get some support through their patient support people. There's some email addresses in the main chat if that would help you. There's someone that says, is the increase in presentation of thick mucus an indication of airway narrowing that should be concerning?
Not always, but I think it's worth checking out. And there are patients we have who that's sort of an early symptom where they're noticing thicker secretions. It's usually pretty easy and straightforward to get checked out for airway stenosis with a combination of your rheumatologist and maybe getting imaging studies or an otolaryngologist where we look with a little camera when you're in the office to understand how your voice box is working and how your trachea is working, or a combination of the two. So I think if there's any question, it's pretty minimally invasive, pretty low risk ways to try to understand if you have airway stenosis. And if you do, I think it's really important to know it so that we can help take care of you going forward.
Right. And someone has asked a couple of different questions, but one is if someone has MPA vasculitis, could this be part of their disease?
Yeah, I think the strongest associations that we see in the airway disease world are with GPA, but certainly the same principles would apply to a number of other vasculitis conditions as well. And so it would be the same symptoms and really the same ways that we would try to take care of things. The combination of minimally invasive surgical treatments to open the airway, and medicines to ensure that the disease is staying as quiet as possible.
Okay, and the next question is ANCA-Vasculitis with septal perforation and marked mucosal inflammation and crusting have a relation to this?
It can, when we looked at the patients of 1,000 patients with GPA and the 15% that have airway disease, subglottic, tracheal, bronchial stenosis, what do those patients look like that makes them different from the patients without airway disease? Well, more often they have problems with their nose and sinuses, sometimes also with their ears. They're all mucosal surfaces in the airway, and we think of them as being sort of connected and contiguous. The immune response moves across all of those pretty equally. And so, yes, I think a lot of sinus inflammation puts you at heightened risk for also having problems in the voice box or trachea, and it's worth checking out. Um, Usually, it wouldn't be that the septal perforation or sinus disease causes lower airway problems. It's more that it just can be a marker for somebody who also has lower problems lower down as well.
Understood. And then I had somebody ask, does taking Rituxin for their GPA help prevent these breathing issues?
We think so. I think the information we have is pretty incomplete, in terms of the highest level of rigor. I don't know that we can know how to prevent it if it's not there to begin with, but it certainly is a mainstay of treatment within the rheumatology community to try to prevent inflammation before it starts, because organ damage, whether it's the voice box or the kidneys or the liver, happens from repeated cycles of inflammation and resolution. And so really trying to stop inflammation from even starting is key. So preventing organ damage from ever taking hold is sort of a mainstay. So my shortest answer would be yes, it's very reasonable to be on rituximab to try to limit end organ damage in other places, including the airway.
Okay, thanks. Here's an interesting one, and I did take this out of the chat. The person's having trouble finding the Q&A. How many airway subglottic stretches can be done? I've had two, and I suspect that I may be due for another one.
Yeah, I mean, we certainly strive to combine the treatments, the surgical treatments with medicines to keep the disease quiet, to limit the amount of time somebody needs to go to sleep, just because it's a burden on you financially, physically, emotionally, obviously. But I don't think there's a real hard and fast limit to the amount of times that you can have this done. And like a lot of things in medicine, it's always a risk to benefit calculation. And so the risk of endoscopic treatment, I think, is overall quite low, and the benefit of having you breathing with a quick recovery is quite high. And so it's a very good trade-off usually for somebody that has airway disease to have these dilations to improve things. So suffering while trying to wait it out for a longer amount of time usually isn't my recommendation. It's to try to treat the disease so that you're doing all the activities that you want in your day-to-day life and you don't feel restricted.
Right. And is there a way to know how soon subglottic stenosis can come back after an endoscopic treatment?
Yeah, I mean, everybody's a little different. Most of the time, people with GPA, it's on the order of 2 years, 5 years,
Mm.
somewhere in there. There are people where it comes back sooner, or if they have a disease flare, it comes back faster. But in general, that would be about the kind of timeline that I see most often for patients.
Okay. And this person asks, what's the success rate of the endoscopic approach? How often do I need it? Which I guess you just answered. Also, would a speech therapist or physiotherapy help with breathing issues?
Great questions. So, I think the timing on the treatments is important. If you're having symptoms, it really is vital to keeping your airway open and keep you breathing safely. And so, how well do they work? I think they're very effective at improving your breathing. I mean, I would probably put it at more than 95% of people who have these endoscopic treatments feel better afterwards. They're not perfect, but they do in large part work, and the recovery is usually pretty easy. It's not asking you to recover very or heal a lot after these operations or these endoscopic procedures. So I'd say I think they're very effective at working. They are less effective at working for a long time or curing you. I don't think that they're, I don't feel like most of the time endoscopic treatments are going to cure people of the airway stenosis. They're going to treat the symptoms. And then we're going to need to watch and make sure that the symptoms don't come back. Because if they do, we'll be there to be able to do it again. So if the question is how long or how effective are the endoscopic treatments at totally curing airway disease, I'd say that's low. But how effective are treatments at improving symptoms on the short term, the 2 to 5 year kind of time frame? I think they're very good.
Okay. And then someone's just asking basically where to get started. She says, when considering having these symptoms to be checked out, who's the best person to try to be seen? Currently, I'm followed by a rheumatologist, but is there a different specialist to seek support for these type of concerns?
Yeah, that's another great question. And usually, what I would recommend would be starting with your rheumatologist and talking with them about your concerns and asking them what they think, because they have a pretty savvy perspective. And so, a lot of times, they have otolaryngologists or pulmonologists that they work closely with that they're able to communicate with and have a relationship and know are adept at managing disease. So, if you have a rheumatologist, I would start with them and ask them that very question. The rheumatologist is also able to get some basic imaging studies, the CT scans of the neck and chest that can help identify problems early and then make it easier for the referrals to the otolaryngologists or interventional pulmonologists.
Okay. Um, Sounds like great advice. There's a question in here. Is there a relation to an increased production of mucus, like coughing and clearing my throat more frequently post subglottic stenosis dilation?
We don't think of the dilation necessarily making those things worse, usually. Um, you do have a lot of little cilia, little fingers that help move the mucus out of your airway. And so if those get disrupted by the inflammatory process of the scar in your airway, sometimes, afterwards you can still have trouble with secretions. Usually we'll treat secretions with humidification and hydration. So really staying hydrated is important, lots of water. And if that's not enough, nebulizing salt water or saline can be very helpful just to keep the secretions from being too dried out and thick. Because that's when people really notice it, is when the secretions get dry, because then they get very sticky and hard to cough out. So staying hydrated, staying humidified, I think are very easy mainstays with very little downside.
Okay, and last question of the day. And this comes back to all vasculitis patients. Can you tell the difference of inflammation from an infection versus the actual GPA with regard to these airway issues?
Yeah, that's a great question. And where does, environmental insult stop and host inflammatory response start? And sometimes, they're both there, working side by side. So when people show up with airway manifestations, they frequently will culture the airway. And so if we can identify bacteria, we'll treat with antibiotics as well, in addition to some of the local immunosuppression from during the dilation. So those would be, how we try to tease those things apart and add in extra medicines potentially for some of the bacteria.
Well, thank you so much. I'm sure we could ask you questions for hours, but we are trying to be cognizant of your time as well. And thank you there were a lot of compliments in the box in the various boxes about how much time you spent with us and how easy it was to understand things. I'm just going to share my screen again and go over a couple more things as we wind up today. Hopefully you all can see this. We should be on that one. So just before we finish up, I want to remind you, all of our viewers, to visit the Vasculitis Foundation's website, where you can find all kinds of help and information about vasculitis. For instance, Under education, you can learn more about the various forms of vasculitis. And as a matter of fact, after you've read all about your form of vasculitis, you can go to the resources tab, and under order print, you can find short documents that you can print out for family or even to take to your primary care doctor's office, which I did recently. And on the VF website, you'll also find a video library with all of the recorded webinars. On the homepage, you can find out more about the patient support groups. Somebody asked about that today in the chat, so that's a good resource for you. Upcoming events like this webinar and others, as well as the Vasculitis Foundation conferences. There are conferences all over the United States. There's a few coming up in November. And I'd like to let all of our viewers know that when you leave this webinar today, a survey is going to pop up. So in this survey, we want to know how you liked today's webinar and if it met your needs. So please make sure to click the continue button so that you can take the survey so that we know how we're doing. Each person registered for today's webinar will also receive a follow-up email with a link to the recorded version of today's webinar once we have it up on the YouTube channel. And as always, I'd like to say thank you to the Vasculitis Foundation for hosting these medical webinars. Thank you to our sponsor, Novartis. And of course, Dr. Gilbert, thank you so much for all your time that you spent in sharing with us today and educating us and answering all of our questions.
Well, really appreciate the opportunity to visit with everybody. So thanks for the invitation.
Thank you. Goodbye, everyone.